Hi, I'm Dr. Jeff Calhoun. I'm going to be giving a quick case study on a RETeval ERG test on a typical diabetic patient that many of you might see nearly every day. So I practice in a group practice in the suburbs of Buffalo, New York. We have 3 docs in our office. Our practice is probably a lot like yours. We see a lot of medical patients every day, a lot of glaucoma patients, a lot of macular degeneration patients, a lot of diabetics on our schedule every day. Our patient base skews relatively older, and it seems like we get more diabetics every year. We brought in the RETeval in April 2023. The main reason was to provide the best clinical care for diabetics as possible, and it's definitely done that. It's helped with patient education. We can show the patients how their retina is both functioning and also its structure. We can show photos with our Optos where the patient may have some retinopathy and is it getting worse year after year or improving. And we also now show their function. We can show how the retina is under stress and in some cases dying. So it's been able to help with education, getting the patients to take their disease more seriously. Every morning, our docs review the charts for the patients coming in the day, and we look to see what kind of diagnostic tests need to be done by our techs prior to seeing the doctor. So if we have glaucoma patients on the schedule, we look to see who needs a visual field, who needs an OCT, who needs an ERG test. Same with diabetics. We look to see which patients are going to need retinal imaging, who may need an OCT test, who may need angiography, or who may need a diabetic RETeval assessment as well. And as we'll talk about later, we try to get as many ERG tests and all the diabetics whenever possible. So the case I'm going to present is probably pretty similar to something that you see in your office every week. This is a 46-year-old male presenting to our office as a new patient. His only complaint was that his contact lenses were feeling drier the last couple of years. He admitted that he tended to overwear them and did not replace them as quickly as he should have. His ocular history was remarkable for high myopia and lattice degeneration. He explained that he never needed any type of laser treatment on his lattice, that his previous eye doctor was only monitoring it. He told me that his systemic history was unremarkable, but he admitted that he did not like going to see his primary care doctor and hadn't been having a physical in a while. His only medications were over-the-counter vitamins. So entrance testing on this patient was unremarkable. Manifest refraction did reveal high myopic astigmatism. Each eye was corrected to a nice sharp 20/20. Slit lamp exam was unremarkable, and his intraocular pressure was within normal range. So looking at the patient's OptoMap scans, the patient had a large cup to disc ratio in the context of a large optic nerve head size. The rim tissue looked healthy. There did not appear to be any kind of notching or any type of Drance hemorrhage. There was, however, a blot hemorrhage and a cotton wool spot in the superior area of the right retina along the superior vascular arcade. So looking at the patient with the slit lamp with a 90 lens and using a 20 diopter lens with a BIO, we did see the lattice degeneration. There was no retinal holes, and I confirmed the intraretinal hemorrhage and cotton wool spot in that right eye. Left eye appeared clear of any type of retinopathy. So I explained to the patient that we found that he had some bleeding in the back of his right eye, and I explained that it can be caused by several different systemic health reasons, but typically it's caused by high blood pressure or diabetes. We measured his blood pressure in office, and it did not seem to be that highly elevated, 132/82. I told the patient that because of the retinopathy, he had to return to his physician, which did not make him happy, but he needed a physical and blood workup to help determine what could be causing this hemorrhages. I also explained that we had to see him in 4 months just to make sure that hopefully the retinopathy was improving and not worsening, and to see if the left eye was starting to get involved. So the patient did not keep up his follow-up appointment. He had previously been seen in my office right before the COVID pandemic hit. He didn't return for the next couple of years. He came in admitting that he did not want to come in during the pandemic, but he did inform me that after his last visit, he did go have a physical, and he was diagnosed with type 2 diabetes, and his physician had started him on metformin. The patient stated that his blood sugar was pretty well controlled, and his last A1C was 6.5, but he did tell me that he hated taking the metformin. He was thinking about quitting it due to side effects, as it was upsetting his GI system. He denied any new ocular or visual complaints, and he said he was happy with his contact lenses and happy with his glasses. During the examination, the entrance testing was unchanged, refraction was unchanged, slit lamp exam was pretty unremarkable. However, now when we looked in the back of his retina, he now had increased cotton wool spots in the right eye and now had retinal hemorrhages in both eyes now. So it's a little bit hard to see on the OptoMap scans, but the patient now has increased number of cotton wool spots on his right eye and now has some intraretinal hemorrhages on both eyes. So I explained to the patient that his retinopathy had worsened and now it's become bilateral. It's now in both eyes. I explained that he needed to keep working with his PCP and his nutritionist on a diet and exercise plan to help prevent further worsening of retinopathy. I explained that diabetes is the #1 cause of blindness in working age public. And I explained that he's now at increased risk for vision loss. I recommend that he return in 6 months for a follow-up retinal exam so we can ensure that his retinopathy wasn't worsening. So the patient did not keep his follow-up appointment. He did not present for 1.5 years. When he came into the office, he told me that he'd actually been off metformin for a while due to the side effects and that his blood glucose had risen up to an A1C of 12.0. At that time, his primary care doc started him on metformin again, talked to him about the importance of using it, and also added Ozempic, which as a result has caused the patient to lose a lot of weight. The patient was now under good control of his A1C. Said the last test was 6.0. He was proud of how he looked. He was proud of his weight loss. He said he felt great. He felt that his vision was as good as ever. And he was a little bit upset that his wife was still making him come in to see us, as he didn't think it was necessary anymore because his diabetes was completely in control now, in his words. And he made a comment to me during the case history that he wanted me to tell his wife after the exam that he was right and that she was wrong because his retinas and eyes were so healthy. And I had no plan to get involved with any argument or bet between him and his wife. But unfortunately, I had to break the news to this patient that his retinopathy had, in fact, worsened significantly in both eyes, despite the very good control of his blood glucose. He now had intraretinal hemorrhages in all 4 quadrants of both eyes, along with more cotton wool spots now in both eyes. And he had hard exudates forming along his right macula, putting him at significant risk for macular edema. You can see on the OptoMap scan how many cotton wool spots he now has in the right eye and now some in the left eye. In all 4 quadrants, he's got intraretinal blot and dot hemes. He's got some macular leakage. You can see the exudates forming along the right macula. Because the patient wasn't dilated yet, we were able to run a RETeval ERG-DR assessment on the patient. You could see in the results that the patient has severely reduced implicit time and reduced amplitude in both eyes. They're flagged in red. The patient's pupillary function was flagged green, though, which shows good pupillary function, not showing any signs of iris ischemia yet, but the implicit time and amplitude was troubling. This patient showed significant retinal stress and probably some existing retinal damage. When we look at the DR score, it came up as 27.6, which is significantly higher above the normal range. We want the DR assessment to be as low as possible. Anything above 23.4 shows this patient is at significant risk for surgical intervention in the next 3 years, meaning laser treatment, intravitreal injections. Unfortunately, this patient's score was 27.6, I believe, which is significantly higher than the 26 mark, which is where patients are at risk for developing the need for surgical intervention the next year. So this 27.6 score was troubling. So I changed the diagnosis to severe non-proliferative diabetic retinopathy in both eyes with possible macular edema. I had to break the news to the patient that he probably is going to lose his bet with his wife. Even though he's feeling great and he lost a lot of weight and has done a great job of reducing his blood glucose, that we now have to send him to another doctor, which did not make him happy. I explained that we needed a retinal specialist to look to see if this patient's macular edema needed to be treated. I explained that we now have proof that his retinal structure is getting worse by showing him the before and after of his retina images with the increased hemorrhages and cotton wool spots. And now we have objective proof that his retina is not functioning normally, showing significant damage. And the patient's probably at significantly high risk of things getting worse soon. So this is a good case that just showed how well the patient's ERG objective score of the patient's retinal function correlates with his retinal structural worsening. And I've learned since this patient that it's not unusual that patients who are on Ozempic or similar medications who have very rapid decrease in blood glucose results in a temporary worsening of their retinopathy. If the patient blood glucose stays well controlled, it's usually temporary and often will resolve over time. And with the skyrocketing use of these medications, it's just making me wonder if we should be performing, DR assessment scores on as many of these patients as we can who are diabetic taking these weight loss medications. So the patient did keep his appointment with the retinal specialist. They did find macular leakage, but not clinically significant macular edema at the time. So he's just going to be examined every 4 to 6 months. The ERG was very helpful in this patient's education because when he saw where his number was compared to the normal range, I do think it helped him keep it more serious and take it more seriously. And he did follow up with the retinal specialist, which I was a little bit worried if he was going to keep that appointment. I do think having the RETeval in our office has been important. It helps provide the best clinical care for our diabetics. It helps with our decision making on which patients to hold our office and monitor our own and which ones we should refer out to retina. And it does differentiate our practice from other offices in the area. And we do try to run this test on as many diabetics as we can. So thank you for listening to this case report. I hope it was educational. Have a good day.